Dear participants, welcome. My name is Nikola Jevtić, and it's my privilege and pleasure on behalf of second ScoSym webinar to welcome you today. We are delighted to have you with us today. Our main goal is to share our experience and knowledge on scoliosis. I'm personally very grateful because we have a lot of many people from different countries attending our webinar. And today, my guest will be covering very interesting topics, and it's a great opportunity for all of us to expand our knowledge on these topics and become better in our work. The most important thing about our job is to constantly ask questions, conduct research, and improve what we already know. All of that for the benefit of our patients. Then, now we'll share presentation with to introduce. The ScoSym Symposium was founded in 2019. Last year we had first ScoSym Symposium, and it was a very successful, and we had a great speakers. Second ScoSym Symposium is postponed because of the general and global situation with COVID-19. And as soon as possible, we will give you the new date for the second ScoSym Symposium. Actually, that is the reason why we start with the webinars, and till end of this year, we will continue have the webinars to give small contribution to our participants. Then I can announce the next webinar will be 27th of June. And we will talk on this webinar about braces and surgery. The organizers of the ScoSym Symposium are the Scolio Centar Novi Sad, Serbia, and CERNS Novi Sad, Serbia. Also, you can see the speakers who should be the presenters, the speakers on the second ScoSym Symposium. And also confirmed sponsors for second symposium are we have gold sponsor is the Center for Corrective Gymnastic Staff, Bijeljina, Bosnia and Herzegovina, and silver sponsor Acıbadem Hospital, Istanbul, Turkey. Confirmed ScoSym exhibitors are the Scoliosis Spine Laser Center, Athens, Greece, and HEDEF Spine, Istanbul, Turkey. Friends of Symposium are the Hotel Garden Novi Sad, Serbia, and Ortho Aid, Belgrade, Serbia. Now I will say some words about my guests today and about their topics. First speaker will be Dr. Fabio Zaina. He will talk about adult scoliosis, current trend in diagnosis and treatment. Dr. Fabio Zaina is the medical doctor, physiatrist currently working at ISICO, Italian Scientific Spine Institute, in Italy, expert in field of scoliosis and spinal deformities. Past president of SOSORD, authors of more than 120 scientific papers about scoliosis and spinal deformities. My second speaker is the Professor Nachiappan Chockalingam. He will talk about the role of biomechanics in providing effective clinical intervention in adolescent idiopathic scoliosis. Professor Nachiappan Chockalingam is the director of Centar for Biomechanics and Rehabilitation Technologies at Staffordshire University, England. He is a fellow of Institute of Physics and Engineer in Medicine. He is also affiliated professor at the Faculty of Health Science, University of Malta. He is a chartered engineer and chartered scientist and a member of various professional organizations. He has been elected to the executive board in some of these international societies. Nachi has a special research interest in the area of spine biomechanics and gait analysis with focus on scoliosis. My third speaker is the Dr. Lukasz Stolinski from Poland. He will talk about photographic method in assessment and documentation of body posture. Dr. Lukasz Stolinski is a physiotherapist from Poland. He works since 2006 in private physiotherapy clinic, spine disorder center in Skierniewice, with patients with functional and structural spine disorders. In 2009, he is cooperating also as a physical therapist in Reka Sport Clinic in Poznan and spine disorders and pediatric orthopedic clinic in University of Medical Science in Poznan. Directed by orthopedic surgeon Professor Tomasz Kotwicki, who is also founder of the SOSOR Society, with clinical and research activity. He is a member of Scientific and Educational Committee of SOSOR Society. Now, I would like to just give some short information about the schedule. First, we will listen to the presentation from Dr. Fabio Zaina, and after that, we will give you 5 minutes to ask the question to Dr. Fabio. And after that, we will continue with presentation from Professor Nachi and Dr. Lukasz. And at the end, you have to ask the questions to Professor Nachi and Dr. Lukasz. Now, I would like to give the word to Dr. Fabio Zaina, and thank you very much for your time, and also thanks to my 2 participants. Dr. Fabio, you can start.
So, ladies and gentlemen, good afternoon. Thank you, Nikola, for your introduction. Thank you for the invitation. Thank you, and also Marina, for kindly organizing this very interesting event. I'm very sad not to be able to be in Novi Sad at the end of June as originally planned, but unfortunately the world has changed quite a lot in the last few months, and this will be a matter for next year for sure, not for this year. The topic you assigned me is about adult scoliosis, current trends and diagnosis treatment. So let's go straight to it, so to leave some time for your questions. This is a quite big topic, so we will just have an overview today, not possible to go deeper in any aspect. So the main topics we will deal with today will be the classification diagnosis of scoliosis during adulthood, the natural history during adulthood and the connected problems, and the treatments based on evidence, mainly the conservative treatments, because I'm not a surgeon, I'm a physiatrist, so my field is the one of the conservative treatment. For the diagnosis, we can roughly say that we can find during adulthood both conditions that are new conditions, like the de novo scoliosis, but we have also former kids who grew up and became adults, kids affected with scoliosis that now gone with their scoliosis being these chronic conditions. So the AB classification is quite helpful in screening among these different conditions, even if it doesn't give directly and immediately indication for the treatment. Whatever the case, AB classified scoliosis in 3 types. Type 1 are primary degenerative scoliosis, also called de novo scoliosis. We have type 2, which are idiopathic scoliosis, which are progressing during adulthood. And then we have secondary degenerative scoliosis, which are a different group of pathologies. Type 1 usually are lumbar or thoracolumbar curves, usually secondary to disc or facet joints degeneration. Frequently, these kind of scoliosis are quite painful, and they are diagnosed as quite moderate initially, with not such a big progression over time, but quite painful, as I was saying. So this is the main characteristic, and also quite difficult to treat. Here we can see a case of a woman with this kind of scoliosis. As you can see in the upper left picture, there was really a moderate curve of 19 degrees, which became in about 10 years a curve quite double, like 42 degrees. You can see in the picture in the middle also a big shift to the right of the trunk, and this lady was suffering with a quite significant back pain. So this is a clear and typical example of degenerative scoliosis, which is type 1 for AB. Type 2 instead are those patients who had a diagnosis of scoliosis during growth and who experienced a progression during adulthood. They can be both thoracic or lumbar, thoracolumbar, usually are combined with secondary degenerative scoliosis or imbalance. They are less painful usually and can progress quite a lot, becoming very large curves of 60, 70, or even more degrees. Here is an example of an old lady who has turned 70 years of age. She was diagnosed when she was a child, when she was 12, and then there was a big progression. You can see the big hump in the thoracolumbar area on the left, the imbalance to the right of the shoulders, and the thoracolumbar kyphosis, so a total imbalance of the spine. She had a worsening quite significant in the last 10 years of 14 degrees during the last 10 years. Sorry for hiding the video, but I think it's better to have the full screen this way. Here you can see this angular kyphosis, and this is a very unbalanced condition, quite painful, and that was the reason why this lady was seeking for treatment. Then we have type 3, which is divided in type 3A and type 3B. Type 3A are secondary adult curves connected to, or depending on, an oblique pelvis due to a leg length discrepancy or a hip pathology. There are also secondary curve in idiopathic scoliosis, which progressed, or neuromuscular and congenital scoliosis, and also asymmetrical anomalies of the lumbosacral junction. And then we have type 3B, which is connected to metabolic bone disease, mostly osteoporosis, that can be combined with an asymmetric arthritic disease or vertebral fracture. So as you can see, the classification of AB takes care of the main different possible origins of the scoliosis, even if it doesn't give back a direct indication for the treatment. For this, it's important to know the natural history during adulthood and the possible problems, namely progression, risk of back pain, breathing and heart issues, pregnancy, problems during pregnancy, the social and psychological impact, and mortality also. According to the data, we know that there is a risk of progression in curves that are further than 50 degrees, above 50 degrees. The natural history is based on a few studies. As you can see, there are 5-6 studies about adults, which really small samples. So what we know about adults, it's a little bit imprecise and should be applied to our patient cautiously. Don't be too dogmatic in stating your future will be like this or like that. The main data on which we rely are coming from the Iowa study from Steve Weinstein and his team. And this was one of the most important core study with long-term follow-up for scoliosis. And they presented data about curve progression at 40 years of follow-up in 102 patients, and data about quality of life at 50 years of follow-up in 117 patients. And all this data refer to untreated patients. About life expectancy, what was documented is that there is no limitation for these in terms for patients suffering with scoliosis. So scoliosis is not a life-threatening event. This must be considered when we propose to our patients invasive treatments like surgery, for example. About respiratory issues, we can say that there can be a reduction of the current volume in patients with severe thoracic curves. This happens usually with curves larger than 70 degrees, but this is usually not a serious issue, and the impact on the quality of life is quite moderate also. Considering hard problems, they refer mainly to very, very large deformities, like curves over 100 and 120 degrees, so it's usually not the problem of idiopathic scoliosis during adulthood. During pregnancy, it's been referred that there is a higher risk of progression, but actually the current reviews don't confirm this, which is traditionally more an expert opinion than something really based on data. So also this one should be considered cautiously when speaking with patients. This is the review I was referring to, stating that there is no evidence that pregnancy itself can favor the progression of scoliosis. And then there is the risk of flexed posture in the later ages. This is another real risk that can have an impact on quality of life and pain in patients. So we must take care of this and try to prevent it whenever it's possible. But what is the future of our patients? Where are they going to? What can we tell them? What should be prepared to afford? In terms of progression, data coming from the study of Weinstein stated that the risk of progression when the curve is below 30 degrees is almost zero in curves below 30 degrees for thoracic curves. And this is based on a small group of 31 patients coming from the Iowa study. And the progression was for curve larger than 30 and mainly for curve larger than 50. Also for the lumbar curves, it's almost the same. On 30 patients, it was shown stability if at the end of growth the curve was below 30 degrees with a small rotation below 20 degrees, while with curves larger than 30 and especially larger than 50, the risk of progression is much higher. For thoracolumbar, we have just 10 patients, which is a very, very small group, so it's really hard to drive reliable conclusions. So pay attention when you communicate with your patient. And for double measure, again, below 30, usually stable, larger than 30, there is a risk which is much higher for curves larger than 50. So the size of the curve, also thanks to the data published by Edgar and Mehta, is relevant both for thoracic and for thoracolumbar, and the risk is related to the size of the curve. The natural history was presented also by Catherine Marti-Poumara in this interesting study where she divided fast progression curves and low progression curves. Usually those progressing more quickly are the de novo degenerative scoliosis, while the idiopathic, which are group B in the study, while group A are less aggressive but initially larger, which are the idiopathic scoliosis diagnosed during growth. So degenerative and idiopathic are different in terms of progression and also in the risk of pain. Here you can see some details from the study, where we can see that at the beginning the curves were much larger in type A, which is idiopathic, and smaller in type B, which is degenerative. Also the age is different, younger for idiopathic and older for degenerative. What happens after a brace treatment has been done during growth? Well, we can say that the risks are not that different from the natural history in untreated scoliosis. What makes the point is to have a small curve at the end of treatment. Here you can see that adolescent and juvenile scoliosis have a quite similar behavior. What makes the difference after weaning is the size of the curve. Major curves larger than 45, the red line, have a higher risk of progression with respect to the black line, which are measure curves below 45 degrees, and also surgery as a trend, which is quite similar to smaller curves. These data are similar to those published by Edgar and Mehta about fused and unfused. Fused have a quite stable condition, while unfused have a risk of progression which depends on the size of the curve at the end of treatment, or in case it's natural history, the size of the curve and stop. In terms of pain and quality of life, according to Danielson and Nachiappan, there is just a moderate reduction of the quality of life due mainly to pain in patients with adult scoliosis. And we know that pain is mainly related to, mainly connected to the sagittal balance. If we have a good sagittal balance, we have less pain. If we have a poor sagittal balance, we have more pain. We know that scoliosis itself does affect the sagittal profile. This is very important, but it's not really the Cobb angle which predicts pain and quality of life, but the sagittal alignment. So this is the background on which we move when we have to face patients with scoliosis during adulthood, but which is the evidence about the conservative treatment. We have just a few studies about the main conservative approaches, which are exercise and bracing. We know from this randomized control trial by Monticone and colleagues that a cognitive behavioral rehabilitation approach is effective in adults with scoliosis, not severe scoliosis, less than 35 degrees, in terms of quality of life and pain. This approach is better than the traditional exercises alone, general physiotherapy, in terms of pain and quality of life. We know from a long-term cohort study by our team, by the ISICO team, that specific exercises, according to the SEAS protocol, which is the same applied by Monticone, are effective in reducing the risk of progression. This was a small cohort of 35 patients, about 30 years of age, and larger curves, 55 degrees, and with many of them had already a demonstrated progression of the curve. This is the graph showing how, with the treatment, the progression rate was slowed down, was reduced in the most of the cases. So as you can see, the change in the trajectory of this patient is really interesting. There are some studies then about bracing, a couple of studies by Morat, which are basically some cohort studies reporting some general data about these patients. But we have a couple of interesting studies, one from Palazzo and Marti Pumarat, showing the rates of progression after a treatment with a soft rigid brace. This is a 3 millimeters brace, not corrective, but really copying the patient. And this was effective in reducing the progression rate, in slowing down the progression rate, which was more than 1 degree per year. It went down to 0.21 per year. And we have a better effect in idiopathic scoliosis with respect to degenerative scoliosis. Here you can see the graph showing the change in the trajectory of the progression in degenerative on the left and idiopathic on the right. And there is also another study from our team showing that on pain, a short brace, a fabricated short brace, can be effective in improving pain. Not that much in quality of life, but for sure pain. These are the changes which are quite fast at T1. T1 is are the results at 1 month, and T2 are the results at 6 months. So a quick improvement, and that a quite stable condition after that. There was not a significant improvement in terms of quality of life. It's possible that in the study the scales applied were not the best, it's possible also that changing pain in this patient is not enough to improve their quality of life. So more research is needed for sure. So in conclusion, we can say that scoliosis is not a life-threatening condition. So we have to be cautious when proponing some very aggressive treatments like surgery, which can be very effective, but which are also characterized by a significant rate of secondary problems or drawbacks. Progression and respiratory problems are correlated to the curve size, the curve angle, while back pain and quality of life is mainly correlated to the sagittal alignment. And there is some evidence, even if of low quality, that exercises, specific exercises, embracing can help in terms of quality of life in patients, this group of patients. It was a pleasure to present this to you. So I just want to tell you thank you very much. And I give back the word and the video to Nikola. And I'm here for your question.
Thank you so much, Dr. Fabio. Now you can start with your questions, and I will use the opportunity always when we are using this webinar to have some conclusion, and because our webinar is followed by professionals, could you recommend and could you give us some information from your experience about the treatment? For example, do you recommend any treatment, conservative treatment for adult scoliosis patients who has curve lower than 30 degrees? And what is the best and effective treatment for scoliosis patients who are above 30 degrees? And do you know the difference between risk of progression between left and right lumbar curve? Thank you.
A lot of things.
Yeah.
So for small curves, what we recommend is a follow-up because there is a low risk of progression, but I've seen some progressing. It's not typical, but it can happen. So it's better when you have concluded a treatment with a kid that you suggest going out with some follow-ups over the time. It could be enough to have a clinical assessment every 3-5 years, but it's different than just forgetting everything for 20 or 30 years and so on. For larger curves, larger than 30, my suggestions depend also on the presence of problems like pain. In case of pain, for sure, I prescribe a treatment. In case there is no pain, the suggestion depends also on the documented stability. If there is documented stability, you can wait and see. If there is not stability, for sure, you start the treatment. I like the most to start with exercises and then eventually to add a brace. The brace many times is added, in my view, today. We are starting, new experience now. Usually at night, so a nighttime bracing for these adults. And it's impressive that in many cases is effective in improving pain. In case it's needed or in case the patients are really collapsing during the day, so it's the case of older patients, you can prescribe the brace also during the day. Then what else?
Just right and left lumbar.
Right and left. I have no data. I mean, the data on adults are such a few. I think that biomechanically, it should be the same. I mean, unless there is if they are both idiopathic or degenerative, I don't think it does make a difference. It can make a difference when you have to make a diagnosis, so there can be more secondary scoliosis and so on in one of these. But if they are all idiopathic, I don't think it really makes the difference.
Okay, thank you. What is the name of the brace to use for adult degenerative scoliosis? That is the first question. That's the question.
It doesn't have a real name. We call it TLSO for adults. It's not very original, but the principle of construction is to follow the deformity of the patients, try not to be too aggressive in the correction, but just to support the patients. And we have, while in the past we used thicker braces, 4 millimeters or super rigid braces like the Sforzesco, now we are using more soft plastic, just 3 millimeters, which is more flexible, and this means more comfort for the patient, but enough support. This comes from the data by Palazzo. I was a little bit skeptical at the beginning, but now we changed and we started making these braces, and they work very, very well, and they are much more comfortable. Before we had a lot of problems of comfort and problems in compliance, because patients really had problems in wearing the brace. So now it's much, much better.
What are the parameters to include the use of the brace for adults?
So first I try to see if the patient is stable. I don't prescribe a brace usually. I prescribe eventually exercises or observation. If the patient is worsening or is quite painful, I consider exercises and eventually bracing. So if exercises are enough, okay. If they are not enough, I go for a brace also. I've seen that many patients are having some good results initially with exercises, but they still experience some pain. And when I add the brace, at that point I see a quick release of the pain. And this is very impressive for me. So we are changing a little bit the protocols. We are adapting these protocols according to the results we are seeing. And we are really trying to personalize the prescription according also to the willing of the patient.
Okay. Do we have time for more questions, Dr. Fabio?
One more, I think. Sorry to...
Okay. One more. What about your clinical experience about adult scoliosis bracing? And we have connecting the question, how many hours is recommended the brace for adults?
So my suggestion is to make not corrective braces, but just supportive braces. 3 millimeters, so more elastic, polyethylene braces. This is my preferred brace today. About the dosage, I like to start with the nighttime, and I see many improvements in terms of pain only with nighttime. I don't have data about the risk of progression because it will take years to collect this data, and we are at the beginning. So I will tell you in 10 years from now. Today I don't have the data. And in case it's not enough and the patient tolerates the brace, I start adding hours during the day. In case of very old patient, like 70 or 80 years old patients, I start more frequently also during the day to ask them to wear the brace also during the day. And usually they are compliant and they feel much better with the brace.
Okay. Dr. Fabio, thank you so much for your time. The presentation was very useful and very interesting, and I really believe that all participants enjoyed. I strongly believe that next year we will see you in Novi Sad, Serbia, and that we will have a second ScoSym symposium with all of you here, and the time will be different. But we can continue to exchange experience online. Thank you so much. Thank you so much.
Thank you very much. It was a pleasure. Sorry not to be able to spend more time with you today, but it was not possible. Next time.
Thank you so much.
Goodbye. Bye, everybody.
Goodbye. Thank you. Now I would like to give the word to Professor Dr. Nachiappan Chockalingam. Professor Nachi, you can start with your presentation.
Thank you for that, Nikola. Hopefully it should work. Does it work? Thank you very much. Good afternoon, good evening, good morning, whichever part of the world you're in. I'm speaking from the UK. It's nice and sunny, although we are under lockdown. I'm sure most of you are still experiencing lockdown, and hopefully we will overcome this pandemic, and we will see you all in Serbia next year. I was really looking forward to going back to Novi Sad. We had fantastic time last year. Nikola was a very, very good host, and we had a great time, and I was looking forward to going back. And it's a pity that I'm seeing you online like this. Now, the idea, what Nicholas asked me is to reduce what I would speak for about 45 minutes, an hour in the conference, to 10 minutes, so that he could convince you all to come over to Novi Sad next year. I think that was the essence, isn't it, Nikola? So hopefully I'll try and do justice to talk about the role of biomechanics in providing effective intervention in adolescent idiopathic scoliosis. We could touch on either congenital scoliosis or adult scoliosis, but probably in terms of time factor, I'm going to stick to AAS. Now, there are several books, papers, websites, blogs, online CPD programs to understand all aspects of spine biomechanics. Although the basic physics concepts or the biomechanical concepts are the same, the way that we look at those concepts and the way that people explain those concepts differ from discipline to discipline, whether you're a physiotherapist, whether you're an orthotist, whether you're a physiatrist, whether you're an orthopedic surgeon. The way that you would look at some of these concepts and their application of that concept slightly differs. Probably that's a discussion for another time. What I wanted to highlight is that although there are several biomechanics textbooks, papers, book chapters, if you want to kind of have a highlight of some of the current concepts in understanding human movement, I'd refer you to this particular book published recently by a good friend of mine, Hans. We have provided a chapter in that book, Stott's textbook on scoliosis and other spinal deformities. There is a biomechanics chapter which we have written. So that should give you a pretty decent highlight of what the current concepts and what we are doing in terms of understanding human movement. Now, having said that, most of scientific research and all papers, published papers, I wouldn't say all, most of the published papers are in the area of low back pain or on whiplash injuries. If you see over the years, the last 30, 40 years, most of spine biomechanics research, most of the concepts and most of the knowledge that we have developed could be related back to some of these clinical conditions which go back to either non-specific low back pain or whiplash injuries. The reason behind that is some of those litigations, high-profile cases, and also some of these workplace issues. And that obviously has a lot of interest, attached to a lot of finances for research, and that's the reason why we see a lot of research in those type of clinical conditions. However, looking at clinical conditions like scoliosis, there is very little research in terms of applications of some of the basic concepts to understand either the disease progression or clinical intervention. So hopefully groups of us trying to get over that and try to understand some of the current concepts, both in terms of etiology and also in terms of clinical intervention. And that's where groups like IRSSD, which is the International Research Society on Spinal Deformities, or SOSART, or SRS and other big professional societies are trying to come together and provide an understanding. Now, having said that, specifically talking about scoliosis, it's important that we have a good scientific understanding, scientific reasoning with any type of clinical interventions. So either it is the development of intervention itself, the design of braces, the design of the instrumentation used in surgery, or the material properties, if it is the material properties of the surgical intervention or the material properties of the braces, whether it is, as I know some of you asked questions to Fabio just now, whether it is a soft brace or a hard brace, what type of braces, what type of fastening, all that comes back to some of these mechanical characteristics of these materials. And that's what is very important. So looking at clinical intervention, looking at the disease itself is one aspect of it. The other aspect of it is to understand the mechanics and how mechanics can contribute, how biomechanics can contribute to not only the design, not only to the manufacture of these devices, but also for an effective clinical intervention. If you don't understand the material properties, if you don't understand how much load this particular structure is going to take, you can't really provide an effective clinical intervention. In that context, it should be clearly, you should understand some of the biomechanical aspects of any type of intervention that you're going to give. And again, that relates back to, as I always say, the clinical outcomes. Either it is a surgical outcome or braces and any type of conservative management, still biomechanics has got a huge role to play. I'm going to leave that point there, but I'm going to probably expect some questions in that space. So I'm going to leave that topic there. But the final thing that I want to talk about there is we need to understand the building blocks, although the building blocks of any type of biomechanical assessment is the movement and the forces. When we talk about forces, it could be the external forces or the internal forces within the body. Talk about external forces, it's a physical activity. It could be walking, it could be running. We're looking at different age kids, their physical activities are going to be different. So one needs to understand what type of physical activity that they're going to take up and what type of forces they're going to, what type of forces that these devices would, what type of forces that are movement that these type of devices would encounter. In that sense, you need to have a basic understanding of biomechanics. To have that understanding of human movement and the forces, there are several types of technologies and techniques available. When I talk about technologies, I talk about some of the aspects of gait analysis labs, like what we have here at Staffordshire. You could see our lab on the left-hand side. That's a picture from our lab. So we have got a full-fledged 18-camera motion analysis system, which would have all these optoelectronic cameras to understand human movement, or ultrasound techniques, or material testing kit, or in fact, look at force or pressure measurement. So all of these type of biomechanical measurements or the technologies would help you to provide you with data. Then once you have the data, then you need to think about appropriate techniques. When you talk about techniques, it's not only using this kit in an appropriate way, it's also about using that data and how to use that data effectively for clinical management. So from our work at Staffordshire, from my own work over the last 20 years, looking at adolescent idiopathic scoliosis, some of the papers that you see up on screen, most of our work is published in the series of books from IRSSD, Research into Spinal Deformities. You should be able to download them via Google Scholar. I would like to highlight two of our papers, both from Robert Needham, who's one of our lecturers here at Staffordshire. His interest is in spine biomechanics. He is building his work as we speak quite a lot. He has contributed to extending the knowledge in the area of spinal segment movement, which I'll talk about in a second. So most of our work so far has been on methodology development. So we have developed aspects of marker placements, some how to assess kinematics, and also some papers which I have not quoted there in terms of pressure measurement and force measurement in scoliosis. So how it all helps you to develop clinical intervention, at the same time assess some of those clinical outcomes. Now, one of the things, without going into the details, if I've been there and have got a lot more time, I'd have gone into the specifics of these marker sets and how it will help you to understand movement. But because of want of time, I'm just going to mention that based on our knowledge on the techniques, what we are doing now is segmenting the back into upper thoracic region, lower thoracic region, lumbar region, and pelvis. And by looking at those movements, we should be able to understand the general movement characteristics in these patients. Now, that's one of the areas that Rob and I have been working on. And currently we're working with various international groups in Sweden, in the US, here in the UK. I'll come to Nikola and Serbia. So we're also collaborating with Nikola and his group. So the idea is to understand segmental movement. Now, when I talk about segmental movement, one of the things that I want to talk about and highlight is that traditionally all biomechanical measurements and biomechanical analysis, particularly within clinical outcome measures, it's all done on linear mathematics. It's good, and it's proven useful in terms of looking at simple angles, simple range of motion. But you should imagine that the behavior of human body, or as we call it as a system, it's non-linear in nature. When you're looking at a non-linear system, then you need to think about non-linear analysis. So one of the approaches that we are promoting, or it's been there for a long time from Bernstein, in terms of looking at dynamical systems. So we are looking at human movement from a dynamical systems perspective. Again, if you look at Rob's paper, some of our work, if people are really interested in this space, you could either follow us on Twitter or send me an email or look at our blog pages. You should be able to pick up some of our references. So what this dynamical systems theory and approach gives you is to explore the rich pattern of movement, as Richard Van Merik says. And also, it also gives us an understanding of the variability in human movement. So when we talk about the variability in human movement, it could be endpoint variability or the coordinated variability. In terms of scoliosis and human movement and what we are trying to understand, we are looking at coordinated variability. So again, this is a whole topic, whole lecture in its own area. I just want to highlight that that's what we are doing. And this is an interesting concept. This is state of the art. And when we, I know Renee came and talked in the last ScoSym webinar series, and Renee is collaborating with us. So Renee and our colleagues in Sweden and in the US and here in the UK and the rest of the group in the UK, we should be able to provide you, the clinicians, with an understanding of how these individual segments work, what is the variability in movement within these segments, which then should give you enough information to see how your clinical intervention works and how you can improve it. Now, talking about biomechanics and some of these approaches that we do, there are several papers. By no means that this is a complete list, or I've chosen these papers in particular preference. I just picked up some of these papers from my database as an example. So biomechanics is used either in terms of understanding some of the etiology of curve progression, like Sabapasha's work in terms of how an S-shaped elastic rod could be used for deformity prediction, or in terms of our Hong Kong group, the friends from Hong Kong, looking at other aspects of imaging and how they are doing modeling, or the work from Canada in terms of all aspects of FE analysis on modeling spine in the computer and predicting what the surgical outcomes would be, and also in terms of conservative management. So all biomechanics is not just about understanding movement, it's also about computer modeling, it's also about material properties and testing materials. So, and again, if you could see this paper here on the bottom left, you could see clearly people using some of these biomechanical principles, some of these assessment principles, to see how they could place pads, place the support structures in a brace, which would help a particular group of patients. So biomechanics display a huge role, and each one of those topics that I touched on today is a lecture in its own right. So for me, 10-15 minutes that I had, it is just to highlight some of those concepts that we have been doing and other groups have been doing. But it is not fair for me if I don't mention my colleagues and collaborators in Novi Sad. Nikola looks a bit sleepy out there, but hopefully I've not put him to sleep. We're doing quite a lot of work with Nikola and colleagues in both in Serbia and Bulgaria with that group of patients, and we are assessing using a novel technique, measuring surface topography in this group of patients who are going through stroke treatment with Nikola and colleagues. So we are getting some exciting results. We are following up these patients for the last 18 months. And the results are going to be published. We are publishing some of the results, and you got a couple of references there. And I'm sure some of the clinicians who are in that picture and also in the wider group would be listening now. So hello to you all, and I can't see all of you on screen, but it is great to see you last time, and hopefully we'll see you soon. In terms of this work, the initial results are really good. And there are two aspects of this work. One is to validate the methodology. The other one is to assess the intervention technique. In both aspects, we are getting really, really positive results. So let me stop there. And in terms of other publications in that space, again, as I said, follow us on some of these social media stuff and on blogs. You should be able to find out as soon as we publish. Now, to finish off, all of our goal is effective clinical management. To have that effective clinical management, make an effective use of technology and the techniques. So it's not only technology. You can buy, if you have the money, you can buy all sorts of technology. It is about using it effectively, and also using the data coming from that, using appropriate techniques and effectively using it. And use biomechanics, try and understand the segmental movement, and use correct segment to assess the clinical outcomes. And most importantly, report your data in such a way that it benefits everyone, both the patient, your clinicians, and if the patient takes the report elsewhere, and the other clinician should be able to understand it as well. So it is about reporting in an effective way so that it benefits everyone. And the last but not least, and I'm a great proponent of that, and we've been doing quite a lot of work in that space, is patient-specific intervention. So again, in the main lecture, I have provided some case series and some case examples in terms of how our biomechanics have helped, our biomechanical understanding has helped in terms of patient-specific intervention. So I'm going to stop there. Thank you very much. And I'm going to hand you back to Nikola.
Thank you so much, Professor Nachi. I just look like this. I'm not sleepy, but thank you. Now I will give the word to Dr. Lukasz. Please, Lukasz, could you start with your presentation, and after that we will have time for a discussion. Thank you.
Okay. Good evening, everyone. Hi, Nikola. It's very nice to see you, to meet you at the web. This is a different way that we do this every year, like we know. So I would like to share you by my presentation. Okay, I would like to present you today some two ways of photographic method, how we can use this method for scientific way and for our clinical practice. Like Professor Nachi said about the upper and lower thoracic kyphosis. We have a lot of measurements to do this, to look for this, but the photography can be very helpful to visually show us what we are doing during our clinical practice, not only in our measurements. So I would like to acknowledge at the beginning to our chief, Professor Tomasz Kotwicki. I think it's with Professor Nachi, with IRSSD society. So our team is living a lot of towns in Poland, but we are cooperating too with our friends from Japan, Professor Nobumasa Suzuki and Pavel Czerny from Czech Republic, which is creating the program to smartphone and to computer for assess the photographic parameters, the rest one. I would like to acknowledge in my specific way, in my private way, to Dr. Grivas. He has the input, very big input to digital photography technique. He agreed to publish the photographic, our assessments, our results in Scoliosis journal, and it was the new opening to do the photography technique in a very scientific way and very clinical way. So this article is open in internet, in PubMed, and in a website of Scoliosis and Spinal Disorders. Very important in the photography technique is that very simple. The photos are we can do the photos in our visits and use when we want to see. The technique is non-invasive and can be very effective. Now, when the time is very hard, like we must stay at home, we are looking for some resolution to how to document, how to measure the patient. Of course, it's not only one way, the most way to do good, reliable measurements, but because we have a lot of techniques, but one of them can be digital photography, and when we will look for a very safe way, we can do the photography in our clinic, or even after some instruction done by the parents of the children. It is a future way, I hope, to our photographic documentation for all the people in the world. Like we know, we should have to use the reliable tools based on evidence medicine, and photography, even it's 2 ways, not 3D assessment, can be helpful for quantitative parameters and using in clinical practice. Okay, one more thing. The most important is that is very cheap, so we don't need to use external markers. We checked in our previous studies that photographic parameters are reliable and standard error of measurements are very small, that we wanted to do next steps and next studies with this, with the photography. Normal values we presented in our previous studies during last years, and now the quantitative studies are still realizing by our team. Few words about standardization of photography. We must put the points, and in some landmarks. So we want to prepare our child to do the photographic documentation in some global way, but very, very stricted by the conditions. We are trying to document the habitual posture in sitting too, and in corrected posture. So we want to look the same for the thoracic region. How is differencing of the body during bending forward, when we are looking for the positions and assessing the rib cage and the movement of the whole body in child. I would like to present you some film for a few minutes. Please wait a moment. I hope it will be this one. Yes. I prepared this film last days because I wanted to show you how looks the photographic documentation in the movie, almost in real. This photographic documentation was done without dots, without markers, because we wanted to do this as fast as possible. At the beginning, we must to position the feet of the child. There is a lot of places to without seeing in the bra and in underpants, because the parent wanted to do like this. But on the photos we can see how the preparation of the child should looks like. At the beginning, we should to show tell the child which position should have and when should be looking, and after this, in this habitual position and the corrected posture position, should do some photos. Before bending forward, we should to told the child how should to move the body, because children are moving different ways, and it's more accurate to do the photographic measurements. And during this, we are doing the photos, which we can use then in different ways. Maybe only for documentation, and maybe for do some measurement of the rib. The way which we should do this as simply as possible, to turn around upper limb positioning and like I said, lower limb positioning. So like we presented in article, at 20-30 degrees of the upper limbs, and moving and telling where should the child looking. So then we are doing the photographic documentation. In my opinion, the most or very important is the same thoracic region. So this way we are trying to tell the child to do corrected posture, but his own corrected posture, and we can see the corrected posture is different. A lot of times different than correct. So his own corrected posture is not accurate, like should to do with a safe thoracic region, for example. And the next steps to bending and to giving the photos, to giving the advices for positioning, and to do photos by next positions. So we have the camera on the tripod. I think it will be some question, but the main height is 90 centimeters, and the distance is 300 centimeters. A lot of authors during last years prepared the study in different distances and heights, but in our previous study we decided these parameters. For documentation scoliosis, the very important is to do the measurement photos by both sides. So then we can have the average for our results, but for child and for parent, we can see the differences of the back, looking on the back. The novum is sitting, is documentation by child in sitting position, like I said, and we have a lot of things which we are checking now. And I hope in the next year in Novi Sad it will be more information to show, to maybe with publish. We will see. Okay. I will back for the presentation. Sorry. So this information could be read and could be seen in our article. So if you will have possibility to look, please, it's open access, so we can do this. Our results based on the Poznań population, Polish population of children, almost 9,500 children from Polish schools, and we prepared percentile charts to photographic parameters and percentile tables when we can see for age and for sex the values of the parameters. During the photographic documentation, we should look for possible errors. In this population of 9,000 children, 9,500 almost, there were above 500 children where we saw some mistakes, some technical errors. So this is very important to do this. Looking for our observations, it was covered total cleft, elevation protraction of the shoulders, different position of the eye level, different position of the upper or lower limbs, incorrect position of the camera. Now the software give us the possibility to move the photo, but it was some error. Autofocus photography, it's very difficult problem when we want to do some photographic parameter measurements. Ears covered with hair, this is important to some parameters in sagittal. Different position of the of two upper limbs in two photos. And there was a problem with some communication of the child. It can be very important too, or standing on the one leg. So how I told you in the published article, we have these photos similar, and we can see the techniques of the measurement of this photographic parameters. There are parameters in sagittal and in frontal. For scoliosis, I think the important is this parameter, anterior trunk symmetry index, and the second one. Okay. And this parameter can give us assessing measurement of the front of the body and show us how can we differ the body, how can be effective our therapy with the patient. It looks like it is by high parameters compared and wide parameters compared. When we want to see to our patients or parents the effectiveness of the therapy, we can do this way, or we can put our parameters of the body, and then it can be more important, more clear for them, because on the photo we see the differences and some changes, but with lines we can do more accurate. And the second parameter, POTSI, by back, very similar. It was the first one parameter created by Professor Suzuki, and the second one was ATSI, which I have a pleasure to create this with Professor Suzuki and our team with cooperation. Doing photography, we can document the posture. We can do this in scientific way, but we can do for our documentation for patient. A lot of times it was very helpful to tell the child, to give him some advices and some input for in the therapy. Okay, and the next examples when we can show the differences. Okay, ScoTech software, which were prepared by Pavel Czerny, is open access too. We can download this from the internet, and we can do this for the computer when we have the possibility to assess the photographic parameters. And now from 1 year, I think, or 2 years almost, there is a ScoDiac for the smartphones, and it's open access from Google Play. We can download this. It's some new resolution. The positions and the parameters, photographic parameters, were measured by different authors in the worldwide. So we presented this on our photography publication. And I think I should tell you something about our clinical practice. This part was for not clinical but scientific way. But now in this COVID time and in the time when we are looking for new possibilities to assess the posture and to show the positioning of the child, which can have impact for the therapy and for our results, I think is very, very important. So, for example, in our clinics, we can trying to zooming for the position, and during the talk with child, we can show the mistakes, errors in which said Fabio, Dr. Zaina said that the daily activities are very, very important. So now we can show our patients how is he look like, because a lot of time they don't know this. So we are trying to catch some positions and trying to tell them what should we change. The rest positioning or during the day, these patients are trying to use the smartphones, and now when we are staying at home a lot of time, it can be very, very dangerous. Differences when a child with corrected posture in standing or sitting, the looking for this is very, very helpful for child. I see in my clinical daily practice and something like this. So when we want to see, like Professor Nachi said about mobility of the spine, so like we can see the mobility of the lumbar region, but the rest can be difficult to understanding why the therapy is not successful. And here, for example, like this activity, we can document and trying to show everything what you want. There is a lot of studies with digital photography now, but I think yet not published. I hope the next time could have a lot of possibility to cooperating and to do some new measurement using the photography. We are trying to look for not only scientific way by photography, but only for documentation. And this is very important, in my opinion, to us, to physiotherapy, physiotherapists, to physiotherapy clinic, to document and to motivating our patient in therapy. Thank you very much for your attention, and I hope we will be able to do new measurements together. Thanks.
Thank you so much, Dr. Lukasz. It was a great presentations, and thanks to my guests. Now we can start with the questions from participants, and we can discuss. And I can start. We already have some questions. And the first question is: the segmental movement has a huge benefit for scoliosis patients. And is there any possibility to be normal when they exercise with specific movement? This question could be for Professor Nachi.
Okay, I don't think I quite understand the question. So, is the question relates? So, I'm trying to kind of recollect what the question is. So segmental movement, understanding segmental movement is very important. Okay, I'm going to give you a specific simple example by sharing this particular screen. Say, if you could see this particular picture, okay, so think about the thoracic segment, think about the pelvic segment. So the thorax movement related to pelvis is the first axis, and then the second one is pelvis down to the lab. So I'm going to put all of these up. So if you could see this, so this is what your typical movement analysis data would look like. So you would get the total range of motion. So start off with 20 degrees, and then it'll give you over the time, it'll give you the degrees. But what you need to look at is, if you look at this segment to the lab axis and this segment to the lab axis separately, then you could see what you're measuring here is the movement between these two. You don't really know what this segment does and what this segment does. So once you understand the individual segments, that's going to give you a lot more information. So if you look at these two graphs, here, one segment starts from 20 down here, the other one is from 40 down going up. But here, the resultant graph, you don't really get that full information. So looking at individual segmental motion is going to give you a lot more information for you to understand that particular patient's movement and also to help them better. I'm not too sure if I've understood your question and answered it, but hopefully that helps. In case if it is not, then come back to me and then I'll try and explain it again.
Okay, thank you so much. Thank you so much for your answer. Second question is for Lukasz. What is the clinical significance of the measurement taken through the photometry? Do you compare the measure in related with X-ray? Yeah, I think it's very important question.
Nikola, can you repeat one more time?
What is the clinical significance of the measures taken through the photometry? And do you compare the measures in relation with X-ray?
No, this is a very important question. Yes, we compare the parameters like ATSI and POTSI, but this is very difficult to compare clinical and X-rays with healthy children, because the results of this Polish big group were based on the healthy children. The small part of the children were with scoliosis. So then we decided to do them some X-rays. And then we tried to show, but this is the smallest group to tell this. But in a scoliosis patient with ATSI, for example, POTSI, the significant differences are small. So we can use this not only this, but with compared more for clinical assessment than for X-rays assessments. Then I'm not sure that I answered.
Yeah, but maybe we can discuss a little bit about it, because it's always important what X-ray show us and what the picture show us. That is the important. And actually, what is the answer from X-ray and from picture? And maybe my additional question or comment would be: do you have the X-ray from this small group who had scoliosis, or you didn't have X-ray at all?
we have only for X-rays. We have only for frontal or to measurement the ATSI and POTSI, for example, but not for sagittal. You know,
Yeah,
because
yeah.
yeah.
Yeah, okay. And did you compare the picture? Because I saw that you put the markers on the processus spinosus, right?
Yeah.
In the lumbar part. And did you compare X-ray with this picture, and this picture gave you similar information as you have from X-ray?
I'm not sure I understand this good. In these patients, in this whole group, no, but we are trying to do this now to compare this together and to have new information more than not only clinical, but X-rays.
Okay, maybe also we can discuss about this topic because I'm always trying to give information to participants in practical way, what is important for their practice. And maybe we can talk also with Professor Nachi. What is your opinion? Is the topography measurements and any other clinical measurements can give us always the, let's say, information what exactly happened with the spine? For example, if we have first clinical picture, let's say topography picture before the treatment, and we have X-ray, and after that, after some time, some treatments, that we have new topography, and do you think that if we have correction in clinical picture, will we have correction in radiology?
Okay, I'm not too sure if I understand your question, Nikola. So I'll try and repeat it, and if I'm making a mistake, then correct me. So your question is, we are measuring either with Lukasz's method or with the stuff that you're doing with us when we are measuring surface topography measurements, whether it will correlate to radiological measurements. Is that your question?
Yeah. So. Yeah. Can we expect from all of these our techniques?
Yeah.
And when we see, for example, correction in clinical picture, that also we have correction with the in X-ray.
Yeah, if you see all the IRSSD papers over the number of years, so IRSSD, the International Research Society of Spinal Deformities, it started off with looking at surface topography 20, 30 years ago. With some of these big names who've been working in this space. Now, from the work that we are doing in Serbia and Bulgaria with your patients, we are already seeing the relationship between some of the radiological measurements and the surface topography measurements. So if you ask me what is the mathematical relationship, whether we can clearly show a relationship, at the moment, we are definitely seeing that relationship. To put numbers to it, we're not there yet, but we will be able to, because we could clearly see the outcomes that you're achieving in terms of exercise, and traditionally you have imaged them to showcase that what you've achieved, and we can do that with our surface topography measurements that we are taking. Now, whether we can do the same thing with photogrammetric based systems, what Lukasz has just talked about, I am not 100% sure. Because with surface topography, photogrammetry measures, or some of the marker-based biomechanical measurements, you still have the skin movement artifact, you still have the soft tissue artifacts, as opposed to imaging. You got to take that into consideration. But definitely, there is a relationship between imaging and the outcomes that you get in imaging and surface topography. Does that answer your question?
Yeah, thank you. Thank you so much. The next question, and I think at the moment is the last question, Dr. Lukasz. How important is the change posture, or maybe just modification is enough for scoliosis? And does changing our position can make stress?
Can you repeat? I'm not sure that I understand.
How important is change posture, or maybe just modification is enough for scoliosis?
We know that in scoliosis, the most important is cup angle. But when we are working with our patient, a lot of times the cup angle is not so important for them, but the aesthetic is very, very, very important. So it should be balanced when we are trying to planning our therapy, to speak with children, to speak with parents, what they mostly want, what they expect. Our goal on the therapy is to have input on for the cup angle, but for patient, the most important can be, especially for girls, to change the aesthetic. So it's difficult question, but we must do the comparison of this and trying to do both.
Okay. And thank you so much. And you also explain us how much is important active daily living for scoliosis patients. And I think that is the very important part. And also that this, if we have good active daily living, that it will be very useful for the treatment, because treatment for scoliosis patients is not just exercise. They have to be very careful about their posture. Thank you so much. We don't have more questions. Thank you so much for your time and for accepting my invitation. I hope that next year we will see each other again in Novi Sad, and maybe before that somewhere in other parts of the world. Thank you, and thanks so much for our participants. Yeah, if you have any more comments, you are welcome. If not, we can close our panel.
Okay.
Thank you very much. Thank you very much.
From me. Thank you, Nikola, and Marina, and Nikola. You've got a fantastic team in Serbia, and I look forward to coming over to Novi Sad to work with you all. And thank you for all the people who attended today's webinar. I could see comments from Thailand, comments from India, comments from Brazil, comments from all parts of Europe, Poland, Greece, and of course Serbia, Bulgaria. So it's fantastic to see everyone, and I look forward to coming over to Novi Sad next year. And I think one of the questions was related to some of these intersegmental movement and dynamical systems. The easiest way to explain that would be to follow us on Twitter, or look at our blog pages, or send me an email. You all have my email address. More than happy to share some of the papers and also explanations on that. Thank you very much.
Thank you. Now we can close our panel. And again, I have to repeat that our next ScoSym webinar will be 27th of June. And we will talk about surgical and brace treatment. You're welcome again to visit our webinar. Thank you so much, and see you in a bit, and see you, and stay safe. Thank you.
The same to you. The same to you. Thank you very much.
Bye.
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 Thanks.